Hi everyone, this is Lisa and welcome to your Mod 9 video lecture. So these are the objectives for this model. We're going to describe the changes in sensory systems and how they impact function. We are going to talk about how physical changes in the older adult affect performance in various life skills, and then we're going to describe the impact of changes in sleeping habits on the older adult. So we're going to start with vision. Vision is central to the way we can relate to and function in the world, but it begins to decline surprisingly early, like around 30. Now, nearly normal vision can be maintained, of course, using corrective lenses, in most people until they are well into the old stage. But the old eye is also vulnerable to diseases such as macular degeneration and cataract that can permanently damage the ability to see. This list is right from your book, describing common diseases of the eye affecting vision and what the functional implications are. Cataracts are by far the most common ailment, affecting nearly 70% of the over 80 population. Now, many of these disorders are very treatable, and some more easily than others. Diabetic retinopathy, for example, which is a deterioration of vision due to the effects of diabetes, is the leading cause of permanent vision loss in this country. And many other visual skills do decline with age. Near vision deterioration, which is called presbyopia, is universal. This is, where all of a sudden you have to hold your book out a little further than you did before. Smaller print becomes very difficult to read, and this is when people start wearing reading glasses. Again, that starts early, around your 40s probably, mid-40s, 50-ish. But there are also things like visual processing speed. It takes longer for people to figure out what they're looking at, for things to go from eye to brain. People become more sensitive to light. Their night vision becomes worse, and this is when you'll hear people say, I just can't drive at night anymore. There are also color sensitivity. It's harder to distinguish between colors. Those types of things. Now, there are some visual skills that are preserved with age. Basic color vision, people as they get older can still tell the difference between red and yellow and blue, for example, or the ability to maintain, it says maintain fixation on a target, to look intently at a target. And there are compensatory measures that older people with decreased eyesight can use to make up for that. Again, this is a list right out of your book, and it illustrates ways older adults can compensate for the loss of visual acuity. Now, some of these are best handled by specific professionals, such as occupational therapists, for example, but many of them can be offered by all of us, such as suggesting larger print books or avoiding night driving. Hearing loss is also relatively common in older adults, with the technical term being presbycusis. Unlike vision, there aren't a lot of disease states that lead to hearing loss as its end, although there are some medications that are ototoxic, which is a technical term for a substance that causes hearing loss. Some antibiotics are the most common culprit, probably, but things like aspirin also can cause something called tinnitus, which is a buzzing in the ear. And in general, older adults lose the ability to hear sounds at higher ranges, and their ability to recall is less if somebody is speaking quickly in a conversation. Again, this is a common complaint amongst older adults, and a big concern is, if it's not corrected, that the person may isolate as a result. No one likes to keep having to ask people to repeat themselves. And we've already talked about the danger that isolation poses in this population. Hearing aids can be helpful, and they are better than they used to be, but they are expensive and not often a covered service. Some recommendations for working with older adults that have hearing loss. Speak in a tone that can be heard. Make sure that you're facing somebody when you're speaking to them. Don't speak too quickly and don't speak too slowly. It says avoid elder speak, and I think that means avoid treating people like children just because they can't hear. Just because somebody can't hear something doesn't mean they can't understand it. They just need some help hearing it. Try to keep the background noise to a minimum, and try to maintain one line of thought while you're speaking to somebody. Now, your sense of smell does decline as we age, and smell is closely associated with taste. So it can lead to a decline in appetite and pleasure that many of us associate with sitting down and eating good food. The other issue with a decrease in the ability to smell is often the first sign of a fire or a gas leak is an unusual odor. As loss of smell is associated as well with COVID-19, this really is an issue that's come to the fore in recent years. Enhancing food with different spices may help, or having another signal for a gas leak in your house, or making sure that smoke detectors are in working order are important compensatory strategies. Again, the ability to taste also decreases with age, as well as the sensation of thirst. It's interesting that the ability to taste sweet foods does not decrease. And you'll see that's true if you go into any nursing home. Often the main meal is barely touched, but the dessert is gone. Having planned fluid intake is important to prevent dehydration. As a general rule, people need to drink about 1/3 of their body weight in non-caffeinated fluids daily. So if the older person weighs 150 pounds, they'll need about 50 ounces of fluid each day. Dehydration is a real common issue in this population, particularly people who have got cognitive disorders as well. So we really do need to make sure that people are drinking plenty of fluid. So we're going to just move on. So that's the sensory issues that happen. Now, older adults, as we reviewed a few modules ago, do undergo some relatively predictable changes that affect the ability to perform day-to-day tasks and decrease overall function. The ability to perform purposeful movements, tying shoes, for example, or climbing stairs, is affected and often leads older people to motion and function experts like physical and occupational therapists. Some of the things are just a decreased range of motion in your joints. Joint contractures, which happens when tendons shorten and it brings the joint in. Decrease in strength, decreased endurance, to name a few. And when there is a decline in function, the overarching goal is to either help people regain the lost skill if possible, or learn to adapt with the ability that remains. These are several ways that we can measure age-related performance. Reaction time, how quick does it take somebody to react appropriately to a stimulus? Gross motor coordination, which is the ability to put your muscles together to perform an activity, how strong somebody is, how long somebody can perform, and what are some work-related performance issues as well. First of all, it's important to recognize that people of all ages benefit from some form of regular movement, older adults included. It's almost always appropriate to encourage physical activity, although of course the type and amount will be dictated by health conditions such as heart failure, for example, which can limit the amount of time a person can do an activity. And goals related to physical activity need to be clearly discussed with the person before they embark on an activity. So these are just some of the benefits of regular physical activity, and not just to older adults. There's pain relieving effects, and not just for arthritis. There is balance effects that happens to reduce the potential for falls. Weight-bearing activities, walking, do work to strengthen the bones and make it less likely there'll be a fracture. It helps people maintain a decent weight. It's imperative for people who have diabetes for glucose control, and it can improve your heart health, all of which are problematic for a lot of people as they get older. Again, clearly physical activity is part of healthy aging, and it is never too late to reap the benefits. Now, reaction time is slowed in older adults with a lot of deleterious results. A fall is more likely to end in injury, for example, as a result of a slowed reaction time to try and break it. But nowhere is this really a more fraught issue than the issue of driving. The loss of ability to drive is a real blow for many older adults, as it represents a lot more than just losing a driver's license. There is the loss of freedom and independence that goes with it. Now, of course, that's not the only thing that's involved in driving, and other issues such as strength and mobility play into it, but it is one big problem that happens with decreased reaction time. Motor coordination is technically defined as the ability to coordinate muscle activation in a sequence that preserves posture, or the ability to move muscles together and remain upright. Now, falls are the most obvious bad effect of that decline, and once an older person has fallen, more falls are likely, and they are associated with an increase in other functional losses as well as an increase in death. Impaired ambulation may be cause for a referral to a physical therapist, some gait training, or even the use of a walker. Now, fine motor skills is the coordination of small muscles in movement with the eyes, hands, and fingers. Now, there's no real age-related decline in the ability to perform these skills per se, but other age-related conditions like arthritis or vision problems make these challenging for a lot of older people. But older adults aging without limitations are just as capable as younger people in completing fine motor tasks. A lot of what we've just gone over really can be remediated with some prompt intervention by a qualified health professional, so it's very important that it's properly identified and referrals made so interventions can start before function is permanently lost. So we're going to talk about work. And in 2019, about 20% of adults over the age of 65 were in the workforce in one capacity or another, and that's up from 10% or so in 1985. Now, obviously, this is higher at the 65 age range than at the 85 age range, but it is a trend that is expected to continue and needs to as this country grapples with labor force issues and very low unemployment. Studies do show that older adults, for example, are less likely to be absent from work. They're less frequently injured in the workplace, and they are really less likely to demonstrate aggressive behaviors or substance use in the workplace. In another module or two, we will be talking about ageism. And, ageist attitudes towards the work performance of older adults really is not based in any type of fact when you look at what the empirical data states. Again, healthcare professionals need to help older workers remain on the job even after the onset of disabilities, and we can support older workers to return or remain at work by encouraging accommodations and partial absences, maybe part-time work as opposed to full-time work, instead of permanent withdrawal from the workplace, which is important to many people. Okay, so we're going to pivot to the topic of sleep now. As many of us know, the lack of sleep, especially a prolonged bout of sleeplessness, can really wreak havoc on one's quality of life. And here's just a review of what normal sleep looks like. We all have circadian rhythms that are loosely based on the 24-hour clock and are in concert with light and dark sleep, our sleep-wake cycle. Light stimulates wakefulness, and as somebody who has worked many a night shift in my time, I can tell you it really does make a difference that when you're very tired, you've been up all night, and you come home and you want to go to bed, it's really important to make the room as dark as possible because the light outside is telling your body that it's time to get up. Melatonin is released as the fall of darkness. So when people take melatonin supplements, which are pretty popular right now, melatonin is not going to make you sleep. It's going to make your body think that it is nighttime. And so taking it right at bedtime, it probably should be taken a little earlier. Again, most of us, or a lot of us, fall asleep generally between 9 and 11 or 12 at night. And we go through several stages of sleep, including stages called the non-rapid eye movement and rapid eye movement, which is associated with dreaming. Older adults don't really need more or less sleep than their younger counterparts. Everybody needs around 7 or 8 hours of sleep, but the sleeping patterns often change as our circadian rhythms change. Many older adults find themselves going to bed earlier and waking earlier, and my own elderly 89-year-old mother does this, going to sleep around 8 or so and then waking up around 3. And that also leads to changes in other habits, like what time you eat dinner or breakfast. A lot of medications also have either stimulant effects or diuretic effects. They make you need to go to the bathroom. And so patients taking these drugs will need special instructions on how best to take them so that sleep disruption is minimized. And there are disease states that can lead to sleep interruption and insomnia. Nocturia, which is needing to get up during the night several times to urinate, is common. Men who have enlarged prostates often find that this is problematic for them. And so, medications may help, or bladder emptying, or those types of bladder training, those types of things can help. But they are definitely part of sleep disruptions that happen. Now, these are just a few of the sleep disorders from your book that can affect anybody, really, young and old alike. Sleep problems don't really discriminate by age. And for many of these disturbances, sleep onset insomnia, for example, having trouble getting to sleep, waking up during the night, those types of things, are often managed with some simple techniques such as sleep restriction or avoiding the urge to nap frequently during the day, stimulus control, shutting down our screens an hour or so before sleep starts, sleep hygiene, which is about what type of routine do you do in the hour or so before you go to bed so your body gets ready, knows it's time to go to sleep, and receives cues that it's time to rest and power down. CBT, or cognitive behavioral therapy, is a type of therapy that in and of itself won't assist with sleep per se, but it can be used to treat issues like depression or anxiety that interfere with sleep. And then there's relaxation techniques, things like meditation, aromatherapy, that can be used as part of the bedtime routine that we talked about earlier. I do want to talk about obstructive sleep apnea a little bit because it's a sleep disorder, but it's also more than that. People tend to think of it as just something that interrupts sleep, that makes you sleepy during the day, but it really has a lot of other effects on your body that can be harmful. And there are obstructive sleep apnea is really one condition that can cause people to stop breathing during the night. Central sleep apnea is another one, but this is probably the most common. And it happens when the muscles that support the soft tissue in the throat, like the tongue and soft palate, will relax. And when these muscles relax, the airway gets narrowed or closed off, and breathing is momentarily cut off. And snoring, somebody who is in bed with a partner and snores all night, the partner will obviously notice that. And that's often a sign of obstructive sleep apnea, and that more workup is warranted. Now, obstructive sleep apnea is associated with a lot of other health conditions. People with untreated sleep apnea are at higher risk of a lot of cardiovascular conditions like high blood pressure and stroke, as well as diabetes. Of course, a lot of the same risk factors for sleep apnea, such as being overweight or smoking, also exist for these conditions. Treatment for obstructive sleep apnea is often what's called a CPAP mask, which goes over your face, is hooked to a device, and designed to deliver pressure that will keep the airways open. These have gotten a bad rap. They are bulky and uncomfortable, so very oftentimes people simply stop wearing them, but they really have improved in design in recent years. Other things that can help include sleeping on one side as opposed to on your back or stomach, using oral devices that are designed to keep the airways open, and in some cases surgery is an option. So, this is the end of this video lecture. Thank you for your attention and enjoy the module.